So after yesterday's talks from Julie and Mary, I'm not sure I have very much to add, but I have half an hour of airtime, so I'll try to fill it. I love this cartoon, and it's old, and many of you have seen it before, but I have 3 or 4 things to say about it. One of them is the date is interesting. The date is the date that there was this famous press conference in the East Room of the White House announcing the final first draft of the human genome. It was published 3 years later. The second interesting thing is that I think we're going to do this, but I don't think it'll be on a piece of paper. And the third thing is that the woman is handing her sequence not to a physician, but to a pharmacist. So this is a team sport. And of course, the fourth thing is he has no idea what to do with it. So when Francis Collins became director of the National Institutes of Health in the United States, he was interviewed by the New England Journal of Medicine. And this is the sum total of what he had to say about pharmacogenomics, typos and all. So what he says, I'm sure that there's a pointer here somewhere. It doesn't matter. What he says is, if everyone's DNA sequence is already in their medical records, simply a click of the mouse to find out all the information you need. There's going to be a much lower barrier to beginning to incorporate blah, 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 blah. And once you've got the sequence, it's not going to be terribly expensive, and it should improve outcomes and reduce adverse events. Usually when I show this slide, I say I disagree with one thing. I think there are 2 things I disagree with. One of them is the not terribly expensive part. I'm not sure about that, and I'm certainly sure that this slide changer doesn't work. What? Okay. Excellent. I'm sure that word is wrong. Because it's anything but simple. So this is a picture of the Vanderbilt not electronic medical record room in the early 1990s. I wish I knew who had the foresight to take this picture. I used to say it was Josh Denny, but Josh Denny was in grade school when this picture was taken. So I don't think it was him. I think it was somebody else more senior in informatics. And I do think the opportunity of converting this mess into electronic records offers a lot of opportunities, none of which I'm going to talk about here except this one. So I think you can find different kinds of people. You can implement genomic medicine, which is what we're talking about here. And then you can do discovery, which I find really fascinating. And I don't think we should lose sight of the fact that as we build these big data sets, there is an opportunity for discovery. So this is a picture of an electronic record. This happens to be our electronic record, our implementation of EPIC. So this is a new slide, because we're newly epicized. And then we have 2 efforts, one in discovery and one in implementation. The discovery effort is focused largely on our biobank, which is large and mineable and has been a great resource for clever people developing new methods. And then, of course, the implementation side requires that you develop the genetic information that you're going to deliver in what we call a CLIA environment. That means more expensive than you would like. That's what it means to me, anyway. It also means chain of custody kind of things, but basically it adds a huge cost. And then decision support, and then an ability to track outcomes. And obviously what we would like is that barrier between the 2 to go away, and as we discover, we implement, and vice versa. So our program that we were tasked to start designing in the fall of 2009, and we were given a year by our leadership, is called PREDICT. PREDICT stands for that thing up there. And the notion that we came up with was find patients who are at high risk for getting drugs that have actionable pharmacogenomic stories. And we've talked a lot about yesterday about what that might be, and I'll touch on that some more today. Genotype them preemptively on a platform that assays many pharmacogenetic variants, so not the specific variant that's attached to the specific drug that you think this person is going to get, but a lot of other things. Store the genotypes, develop the informatics tools, deliver advice at the point of care, track outcomes. That's what I call the easy part, and that's being facetious. I hope you understand. So 2 stories about high-risk patients. One is we engaged our biostatistics friends to look at a large number of patients who had made Vanderbilt their medical home. So they come to Vanderbilt at least twice a year for the last 3 years. mainly to see their primary care physician. And the question is, how many patients receive drugs that have a recognized pharmacogenetic story? And lots. So 65% received at least one of those medications within 5 years. And interestingly, 15% received at least 4 medications on that list. And when we sort of added up what would have happened had you had a reasonable preemptive pharmacogenetic program with mitigation of adverse drug events in place, there was the number was high 300s, 383 preventable adverse events out of 52,000 patients over a couple of years. So we developed this flow chart to figure out how to get things into the flow of care. There was at the beginning a long and tedious evidence review process that involved looking at the literature, weighing the literature, seeing which variants are important, what the alternative therapies are, all the things that you heard about yesterday. Looking at professional societies, which are not very useful, and what the FDA says, which was a little more useful to us. And then, if possible, to replicate signals that we looked at in our biobank. We would develop a plan for a specific drug-gene pair, bring it to our Pharmacy and Therapeutics Committee, who have ultimate authority over how drugs are used in our hospital, and then we would implement with decision support. So the one change that we have now is, of course, we don't spend a huge amount of time going through the primary literature because Mary Relling and her colleagues at CPIC have done a lot of that legwork for us, and that's a huge boon. So that was one way of choosing people who might be at risk. The other way is listening to the FDA. So while we're planning, this is about 6 months after we were charged with planning this effort, the FDA issues this black box around clopidogrel. Consider alternate treatments or treatment strategies in patients classified as CYP2C19 poor metabolizers. And I cannot resist, as a clinical pharmacologist, saying at this point that the fact that CYP2C19 is polymorphic was discovered at Vanderbilt by this man, one of my mentors, Greg Wilkinson. He was studying a drug called mefenitoin, a drug that maybe Munir has used, but nobody else in this room has even heard of, and took a lot of grief for studying a dead drug. But I think this illustrates really, really nicely the importance and the connection to basic science that our field relies on. We also talked about this yesterday, and I thought these are not slides I made up yesterday, but we talked about this idea. So with respect to clopidogrel specifically, there has been this argument about how useful is the pharmacogenetic piece, how does it contribute, and what people want, what people who don't think about this a lot want, they want an answer. Is this patient going to respond, or is this patient not going to respond? And that's a black and white view of the world. And what modern pharmacogenomics does, in general, there are obviously exceptions, is provide this shades of gray. So it's more likely this patient will respond, less likely this patient will respond. And we heard a lot about those kinds of phrases yesterday. So here are the source data for clopidogrel. The drug was approved in 1998. It was known to be a prodrug. The bioactivation pathway had not been defined. So that's 1998. And in 2006, a group of French investigators published this paper where they took a small group of people who were star 1 for CYP2C19 and star 1, star 2, so heterozygotes, and looked at platelet reactivity, which is the y-axis, at baseline, and then after 7 days of 75 milligrams of clopidogrel a day, which is the standard dose. And what you can see is that there is an antiplatelet effect for the wild type people with the wild type genotype, and there is, on average, no antiplatelet effect for the people who have the variant. But what you can also see is that there are some wild types who have no antiplatelet effect. There are some people in this group who have a big antiplatelet effect. So that's the real world. And the likelihood that a single SNP completely drives the response is small. The time passes, and then 3 or 4 groups look retrospectively at their large data sets comparing clopidogrel to placebo or to other therapies. And this is a subset analysis from the TIMI trials group. And what they did was they looked at clopidogrel versus placebo trial. They looked only at the clopidogrel arm and then asked who carries a variant in CYP2C19, mainly STAR2, and I'll come back to that in a second, and who does not carry a variant. And the ones who didn't carry a variant had a lower incidence of serious adverse cardiovascular events over time, and that was statistically significant, a retrospective look. And it looked like the number needed to genotype was about 25 to avoid one adverse outcome. So I said one of the things we tried to do is replicate in BioView. We did that study, so this is the same data I just showed you. These are data from BioView looking at about 600 people started on clopidogrel after having a stent put in, and we see exactly the same thing, that there's a higher event rate in people who have STAR2 or STAR1 STAR2. There's a smattering of other genotypes in our population, truly a smattering. So we implemented. And the first thing we implemented, as I talked about yesterday, we brought a very, very elaborate plan to an oversight group that I didn't talk about in our institution, but that's part of what we do. And they looked at our very elaborate plan and they said, you know, no one's ever done this before. Why don't you just implement STAR2 and see what happens? And that was actually pretty good advice because we were rolling out a new plan and implementing a lot of different drug gene pairs at the same time with heterozygotes and homozygotes would have gotten complicated, still got complicated. But this is what it looks like a little bit later in an old electronic medical record format. So the drug gene pairs are up there on the front page of somebody's electronic record with a link to a website that explains what all this means and active decision support if a patient is prescribed a drug and they have a variant genotype that requires advice about changing the dose or changing the drug. And this is what the advice used to look like. I'll show you what it looks like now. Parenthetically, we share this clinical decision support. We share it in a joint effort with Ignite, and Julie probably knows a lot more about this than I do because she has something to do with the Ignite toolbox. And so she can tell you all about what the sharing is about. But I think that's really important as people think about implementing it. It's like CPIC. Why would you reinvent the wheel over and over again when other people have done this? So this is in the public domain. The other thing that I have to say something about, because some of you are geneticists and some of you are pharmacogeneticists. And it turns out that those aren't congruent communities. In fact, in many ways, the genomics community hasn't spent a lot of time thinking about pharmacogenetics, and the pharmacogenetics community hasn't spent a lot of time thinking about contemporary genomics. I hope nobody's insulted excessively by what I just said, but one example of how the two communities don't talk to each other very well, and I don't know how to solve it, is this star problem. That's not meant to be a swear word. It's just that pharmacogenetics has a problem with the star nomenclature. So the result off of a genotyping platform is this variant. And this is what CPIC does. They take this variant at the nucleotide level with standard genetic terminology, translate it into expected function, then translate it into something called star5, which the geneticists hate. But that's the way we've been doing it for a long time. That translates into myopathy risk and a piece of clinical decision support. So at some point, the two communities are going to have to come together, and we're working on it. We also have a Warfarin Advisor, which I'll just show here. The Warfarin Advisor is much more complicated because it does two things. It extracts information from the electronic record automatically. Then you have other information that is added in by hand. The genetics are added in, and then a weekly warfarin dose recommendation is issued, and you have to translate it into milligrams per day. At some no one gives 2.4 milligrams per day, so you have to translate that into something that makes sense for the patient. We have changed our electronic record about. My mind is gone, but about 3 months ago, we changed to Epic, and so everything's been rewritten. But we now deliver pharmacogenetics misspelled, but we delivered the pharmacogenics panel. That's been corrected, but it was hard to find these data for a while. I mean, because people didn't know how to look for it, not surprisingly, and we've rewritten the decision support as well. So that's all underway. And as I said yesterday, one of the questions I get from cardiologists now, the pressing question is, how do I find that test? How do I order it? Because it's not very simple. Now you have to type in pharmacogenetics before you have to type in pharmacogenics. We've also taken advantage of this hiatus to redesign our platform. There was a long and complex. We had a not very robust platform, this thing, at the beginning. So we've redesigned it, and the main redesign is that we've now incorporated CYP2D6. That is, and as we talked about yesterday in a number of the talks, CYP2D6 is painful because it has this copy number variant thing that you have to do a separate assay for as well. So those are that's where we are with respect to our data set. So in the first 13,500 patients, this is what we got. The vast majority of these people are star 2, but there are a smattering of star 4, star 3, star 6, and star 8. And I'm sorry for the star nomenclature again. The 2.7% are homozygous or compound heterozygotes. So those are the people who, if they're given clopidogrel, that is tantamount to giving them placebo. So to the extent that you believe that somebody should get clopidogrel after getting a stent, these are the people you want to do something else for. There's 20% are heterozygotes, and if you know that, you can either increase the dose or switch to something else. And then there's a bunch who have no variants. So if you're a cardiologist, you look at this and you sort of say, well, there are so many other things that go on with these patients. There's so much variability, and we're talking about a difference in event rate in thousands of patients between 12% and 8%. Then the argument for doing the testing to find that small number of patients is hard to justify in a very, very, very busy workflow. At least that's what our cardiologists tell us. The other fly in the ointment, which I mentioned a couple of times yesterday, is that if you look in very large data sets now, there are, as usual for every gene, tons and tons and tons and tons of other non-synonymous variants. We have no idea what their function is, but presumably these also contribute to variable responses to drugs like clopidogrel, and we just need to know at some point what they are and whether they're functional or not. And those are just non-synonymous SNPs. And of course, star 2 is not a non-synonymous SNP, it's a stop. It's a splice variant. So Sarah Van Driest at our place looked after we had accrued 10,000 people in PREDICT, and then basically just looked at how many people have something serious. The serious is the 2.5% for clopidogrel. That was 2.7 on the previous slide because the denominator is a little bit different. And how many people have something you'd like to know about? That's blue. So for each of the drug gene pairs on the bottom, we have a group of people who have something that you'd really like to know about because you really want to change what's going on, and a group of people who have something that would be interesting to know about and you might want to change what's going on. And when we summed it up, it's about 5% of people have something serious, and 91% of people have something. And that's just 5 drug gene pairs. And you've seen these data in a number of different forms from another number of different groups. It's always the same. Everybody has something. And you just don't know what it is. I'm fond of saying we're all genetic sewers. And this is a shameless plug. So the question is, if you have a bunch of GPs, how do you educate them in what all this means? My modest proposal is that you go to Case Studies in Personalized Medicine, which is a massively online course put on by our institution. And actually, I spent hours and hours of my life recording little vignettes. And so this is the website, and this is me talking about area under the curve. So for those of you who want to teach yourself, there's a couple of pharmacogenetics modules in the middle of all this. There's a cancer module, or 2 or 3 or 4, and there's a diabetes module, what have you. And there are over 12,000 learners. I'm not sure if that's that's the term they use. I'm not sure what the right term is. So the PREDICT model, at the end of the day, when we rolled PREDICT out, we got patients from 2 different sources. That's important because I'm going to give you some outcome data, and the outcome data obviously depends on who goes into the study in the first place. So there are 2 kinds of people. One is people who are who look like they're going to go to the cath lab. So some of those people sort of arrive in the holding room and they're going to the cath lab. Other people have an appointment and they look like they're going to the cath lab. So that's reactive or indication testing. And then there's a group of people who were patients in our medical clinics who had a score that was developed by the biostatisticians who did this Vanderbilt home study. And the score basically just said, what is their chances of having exposure to clopidogrel, simvastatin, or warfarin in the next 3 years? And people with a high score ended up in the left-hand column. So people ended up in PREDICT for two sort of separate reasons. And this is what happens when you do a preemptive program. There are 12,000 people in this particular analysis analyzed. And of those, 2,600 ended up on getting clopidogrel or being exposed to clopidogrel. So when you do a preemptive program of this type on scale, many patients will be genotyped, and the genotype data will be just stored, awaiting its use. And not everybody has it at the beginning. And you can see the numbers here. The numbers are very similar to the numbers that I've just told you about. So what we've done is we've looked at whether physicians respond to this information. What do they do when they get this information? So if patients have 2 loss of function alleles, the conversion rate to something else is over 50%, it's 58%. So 43% or 42% of people still on clopidogrel after a year, but most people have changed. People who have the wild type genotype or diplotype mostly are still on clopidogrel. And what's interesting to me is that if you have one variant allele, the conversion rate is intermediate. So doctors, there's a gene dose effect, and doctors are not complete idiots. They understand that this is the bad one, this is the not so bad one, and this one they can ignore. So it's a nice demonstration of that. And then we've looked at other clinical predictors of a switch. This is work by Josh Peterson, one of our informatics guys. So if the patients are perceived to be at high risk for bleeding, the switch rate is higher. The switch rate is lower because the alternate drugs have a higher bleeding rate. And then if the result is available early, then the likelihood of a switch is higher. If the result is delivered to the practicing physician 2.5 weeks later, then the patient's gone home, they're on clopidogrel, nothing bad has happened. Julie showed you data yesterday that the event rate, when the events occur, they occur in the first week or two, so the switch rates are lower. Then we have a lot of questionnaire data, which I can go through question by question, but I think that it's interesting. People believe in genetics. They don't believe in genetics so much for warfarin as they do for clopidogrel. But there's a group of skeptics, and then there's people who think it's probably important. They just don't implement it as often as we would like. I thought that guidance from national standards organizations is the place where people look. So they look at the American College of Cardiology or the American Heart Association guidelines. They don't look so much at the FDA. That's a big difference. And luckily, whenever a lab tells them that they should order a test, they ignore that. And I think this is the biggest determinant of whether you switch. So this is how many people are on clopidogrel, the proportion of people on alternate therapy if you have no actionable variants and if you have actionable variants, and each pair of dots is one practicing physician, one high-volume cardiologist. And so there is, as we say in the pharmacogenetics business, there's interindividual variability in this particular metric, and I wish I understood it. But there are some people who are big adopters, and there are some people who are just not. But everybody has some patients who change. And you saw these data from Julie and the IGNITE group yesterday. And the main point, I think, is that if you end up with a loss of function allele and stay on clopidogrel, the event rates are much higher than if you don't have a loss of function allele or if you switch. And I wanted to just end with this vignette, which has little to do with preemptive pharmacogenetics, but I think it makes an important point about why it is we're doing all this. So this is a cold email that literally arrives in my inbox as I'm preparing medical grand rounds at Vanderbilt. So it's very time I showed this. So this woman lives in a neighboring state, wondering if I could help her or lead her to somebody to help her. She came across a SNP that she has. She did 23andMe. She found that she's GG for RS 1805124. I can tell you all about that one in a second. From what I've seen, it's apparently rare and pathogenic, something to do with the heart. I'm very scared. I was wondering if you could help me. I'm worried this SNP means I might have a heart problem. I'd be so grateful, blah, blah, blah. So it turns out that SNP is a very common non-synonymous variant of the cardiac sodium channel gene, which is one of the genes that I study. Its minor allele frequency is 25%, so the likelihood that it's pathogenic is about 0. And although people have said maybe it's a modifier of other things, but it's not there. So I told her all that in a very, very long email. And this is her response. I can't tell you how much I appreciate it, blah, blah, blah. Really, I'm a highly anxious person. I probably should have never gotten my genome sequence, which of course you didn't get to begin with, because it's only made my anxiety so much worse. One of my biggest fears is sudden cardiac death, and this SNP really played into that fear. So she is 28 years old. She came to our clinic because she wanted another echo. She also was convinced she had hypertrophic cardiomyopathy. She wanted another echo. That would have been her 5th echocardiogram. And we declined. But so we are going to run into people like this. Perhaps not so much in the pharmacogenetic space, but I think even there we're going to run into people. And we all do run into people who are very sensitive to every medicine. And can't you do something? And then they get access to data that is just half right or quarter right. So I think engaging the patient population is something that we just have to sort of do as part of this NHS initiative. We engage our patients in a patient portal. This is the old version, but the new version looks very much the same. So people can actually go and look at their results in the patient portal, look at an interpretation of their results. And I think that that's probably an important thing to do, especially in an era where you're not sure who owns the data. And if a patient is genotyped at Vanderbilt and moves to Seattle 2 years later, how are they going to make sure that the fact that they're a poor metabolizer gets transmitted to their new doctor and implemented when they are exposed to clopidogrel? And we talked a little bit about that yesterday. I think pharmacies are one way to do that, to manage those data, and patients probably are the other way. So I'll just end with this little vignette, which I got from Josh Denny, a patient that he was involved in. It wasn't a patient of his. A patient with diabetes, family history of heart disease, high cholesterol, admitted for chest pain, gets a stent, January of some year. And clopidogrel started. And then, over the course of the year, has multiple admissions, multiple stents, multiple interventions, until she's finally discovered to be a STAR2 CYP2C19 core metabolizer and switched to prasugrel and all that stuff. So that is what personalizing medicine at the pharmacogenetic level means. And of course, the trick would have been to do that here, not there. But we're getting there, and it's only programs like the ones you've heard about from me and from Julie and from Mary that will start that. And I hope the NHS will do that on scale. So thank you very much.